Slipped upper femoral epiphysis, also known as SUFE or SUFE in short. So this name is rather a misnomer because the epiphysis is held in the acetabulum and therefore the metaphysis moves upward and outward. So a name like slipped metaphysis would have been more fitting. Okay. So under etiology, the cause of SUFE can be largely divided into two main categories, that of your mechanical factors as well as your biochemical factors. So mechanical factors would include obesity, increased femoral retroversion, increased physial inclination, deeper acetabulum because a greater coverage leads to more shear stress across the physis. Whereas under biochemical factors, that usually occurs during puberty. Okay, so this presentation usually during puberty because the estrogen decreases visual width and increases strength, whereas testosterone only decreases the strength. The other biochemical factors would include hypothyroidism, hypogonadism, and growth hormone supplements. It is important to note that SUFE in children below the age of 10 and over the ages of 16 is almost always associated with your endocrinopathies, so always look for that. On clinical presentation, it is usually of a male predominance. That does not mean that it doesn't occur in females, but it is more commonly seen in males, the mean age of 9 to 16 years old, and they can also present bilaterally. Clinically, they can also present with an acute slip or a chronic slip. An acute slip will sometimes mimic a hip fracture, so it's important to add that into your differential diagnosis. Under a chronic slip, the children usually present with a leg length discrepancy as well as gait, decreased internal rotation, leg held in external rotation, and with flexion of the hip goes into abduction and external rotation. Sometimes there could be pain in the distal part of the thigh or the knee. So management as well as prognosis would depend on the degree of severity of the slip as well as your classification. So the classification system we use is known as Loder's classification. That divides our slips into your stable slip as well as your unstable slip. So a stable slip is essentially when a child is able to walk with or without crutches with an AVN of 0%. An unstable slip is when they can't walk with or without crutches and an AVN of up to 50%. The grading of the slip is the amount of displacement of epiphysis on the metaphysis. And here demonstrated, you can see that there are two different ways of grading the slips. The first one is divided into thirds, whereas if it slipped only a third down, it would be mild, 2/3 moderate, and 3/3 severe. In the other grading scale, we have percentages. So you divide the metaphysis into 0, 30, and 50%. Okay. Here is a combination of the two, whereas mild is less than 30%, moderate 30 to 50%, and severe more than 50% slip. So treatment. Usually we do an in situ stabilization with your cannulated screws. Rarely for your severe slips, you can do an open reduction as well as a femoral neck osteotomy. For residual deformity, it can be corrected with a flexion, internal rotation, subtrochanteric osteotomy.